Sirens, Slammers, and Service, a podcast for female first responders by female first responders. My name is Nikki Clucci, and I will be your host. As a former correctional officer in Alberta for almost 2 decades and the founder of Blue Line Fitness Testing, which provides law enforcement fitness testing and first responder wellness workshops, I started this podcast as a way for female first responders to share the trials, tribulations, and triumphs of their daily work. I want to showcase the unique perspectives, skill sets, and personalities that women bring to a first responder career and share their stories. So get ready to laugh your ass off, learn a whole bunch, and be inspired by some pretty badass women. Let's go. Welcome back, guys. We are back today with legitimately my best friend. I know I say that all the time. I know I always say that I have, like, these are my BFFs, but this girl is legit my best friend. We've been best friends for forever. I'm joined today by Shannon Johnston, who is a nurse in the Calgary area. Shannon has been a nurse for the past 15 years. We met each other through rugby. She has been there through all of my ups and downs. She was there when I got married. Actually, she was like a lifesaver the day I got married and came and tied sashes around chairs and made me my veil. And she was there when I had all three of my girls. Has been an integral part of my life. I love this person with every ounce of my heart. Welcome, Shannon. I'm so pumped to talk to you about this today.
Oh, thank you. That was such a nice intro. Thank you. Because if I'm on this podcast, I assume you consider emerg nurses as part of first responders. And we almost never get locked into the first responder profile. We're always seen as hospital staff, but we deal with a lot of shit where people are stabbed or shot and they're like kicked out of their door from the car and left on the sidewalk for us to pick up while the person's driving away.
It's crazy. And so the other part of Shannon is that, when you first got into this, we started talking and then you would tell me stories and we would compare stories between the jail and emerg. And I would say, oh yeah, we were in emerg with an inmate, and you'd be like, yes, I know, I saw so-and-so there, or I saw, your counterparts in the Calgary area with inmates, and oh yes, we've had to deal with them. And oh yes, there was a stabbing at the jail. Yes, we got them. And I would think, yes, this is my girl. She understands what I'm talking about. And your partner was a paramedic and is now with Calgary Fire. Super exciting. Love that for him. I think that's amazing.
They're looking at bringing paramedic role into CFD, but he's also, still picks up a lot with AHS casually. But yeah, he's loving his new firefighter role.
I didn't know that he was still picking up casual. That's awesome. Good for him.
Because when you first start off as a firefighter, you make like $25 an hour less. So he has to pick up.
He's like, we got to make the money. We got to make the money.
Yeah.
I love
pay
it.
The bills.
Yes. Okay, so let's get into you. I want you to tell me your story. Tell me about, I know part of it. Again, as I say, every time I interview people, I learn something new about my friends every time I interview them. But, we had talked about your move into nursing as it was happening, but tell me about it. Tell me, what kind of drove you towards this career, and kind of the ups and downs throughout it, and where you've been and what you're doing now.
Yeah. Okay. Well, I have a previous degree in chemical biology. It's basically a double major in chemistry, and done that degree with the intention of going to medical school. But when I was done that degree, I just wasn't sure. It took me 5 years, and I wasn't sure if I wanted to carry on with more school. And to be quite honest, I was a little bit in my head, and I was to write the MCAT, and yeah, I don't know. I just felt like I wasn't maybe good enough for medical school, or wasn't worthy of that. And so I just decided to get a job using my degree. And of course, there was no using my degree, which is, I used to live in Kamloops, and that's where I did my first degree. And there's not a lot of jobs for chemistry or biology in Kamloops. And so I had moved to Edmonton, which is where I met you, to use my degree. Using it there, and it was just really mundane work. I was working in labs. I was proud that I was using my degree because there was lots of people that I graduated with who were still working at milestones in Kamloops instead of actually using their degree. So I was proud that I was actually using it, and I was, working in a chemistry lab, biology lab. But it was just sort of like the same thing over and over again. And there was a woman that I worked with, who's our age, and she was telling me about this accelerated nursing degree program at University of Calgary. It was a nursing degree in 20 months straight through. So like taking a 4-year degree and compacting it into 20 months. And I'm like, no, that sounds like a good thing. So I didn't want to do a full four years to become a nurse. Well, it's kind of like, being a doctor, you get to do things and, you get to play with medicine and take care of people. So, I mean, can't be that bad. So I applied to the program. It's a very competitive program. I honestly didn't expect to get in because you need a minimum of like a 3.6 GPA. And, like there was like over 300 applicants for 40 spots or something like that. But I didn't get into the September program, but I was offered a spot in the January start. Ended up moving down to Calgary from Edmonton and did the nursing program in 20 months straight through. I wouldn't say that it was hard, especially not compared to my first degree. That was a hard degree, but it was a lot of work all at the same time. So it wasn't like difficult, hard tests or anything like that, but it was more of like just doing like a lot all at the same time. So I graduated in the fall, and it was at a time where you could just say to the people, like say to management, I want a job. And they'd be like, okay. And that's basically what I did. I heard that labor and delivery was a good spot to start because I wasn't really interested in like general medicine. I always knew that I wanted to go to emerg from nursing school. You just don't know enough as a baby nurse. You need a lot of experience to be able to work in emerg. So I went to labor and delivery first, and I walked into the manager's office and I'm like, hey, I'm about to graduate. I want a job. And the manager was like, cool, you have a job. Started working in labor and delivery and got my, first couple years nursing experience there. And it was good because you dealt with adults, you dealt with, neonates, you dealt with some very acute situations, especially because I worked at those level 3 nursery. So it's like the highest level of NICU that you can have. So I had a lot of patients over the years who were, like high comorbidity. They were like very high risk, having like bad outcomes. And so the level 3 nursery was literally right beside us. And so it was good experience. But then once I started to get bored, which I get bored easily, I knew that it was time to move to emerg. I started in emerg in January of 2011. And so the emerg that I started at was like at the Foothills Hospital, which is the level 1 trauma center. All the major traumas in Southern Alberta. It's the cardiac center. It's the stroke center. It's where heart attacks come to go to the cath lab. Yeah, we're pretty much the destination for a lot of things outside of like vascular surgery and outside of like very busy emerg department. And I've been there, for the last 13 years, I guess. That's crazy.
It is so crazy to me that you've been in emerg for 13 years. Like even when we were talking and I was like 15 years. Oh my God, she's been a nurse for 15 years. Like that is just. I
haven't been there full time. I dropped down to like part-time and casual there. In the last 4 years, I want to say I've been part-time or casual. And pre-pandemic that I did that because I don't know if I would be able to tolerate being like in a full-time line in emerg during the pandemic. So it was really rough on a lot of nurses in emerg.
For sure. I can't even I thankfully never had to go to the hospital during the pandemic. I did slice my thumb open like a fucking total idiot on a can and had to like go to the Medi Center and get stitches as the pandemic hit. And I was like, oh my God, like who's the fucking idiot that does this? Right. But that was bad enough because it was like, you were gowned up, masked up. And like, that was me as the patient. And I was like looking at, the doctor and the nurses that were in the Medi Center and thinking to myself, holy fuck, like I can't even imagine this in the hospital. And then like, talking to other friends that were working in the hospital, respiratory techs and stuff like that, were, like you're just constantly gowned up, masked up, like the shield on, like all of that on top of just trying to do your regular duties, right? Like
the isolation fatigue was huge. And the hospital actually wasn't even that busy. Like if you walk in laceration, that probably would have been the quickest you ever got stitches in emerg on your life because the hospitals were like dead. because nobody was going to the hospital. Everyone was scared of the hospital.
Yeah, the whole extension level though of the pandemic, I think, is what you're saying that led to the fatigue. And I mean, the other thing I was going to say too about, the amount of time you've worked in emerges, you also hit a level of burnout. Like, I mean, and just in the general day-to-day work of emerge, right? The
Yeah.
constant busyness, the constant level of, again, trauma, like just go, 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 go all the time. And people are not fucking nice to you guys. Like, I've said this over and over and over again. Like, I could never be a nurse. I am not nice enough. You have to be nice to people. I am not nice enough.
Well,
but like, you have to have like
I will say this, if we don't tolerate abuse. And so I have said some things to patients, family members, whatever, nothing that's like really inappropriate, but also not tolerating their shit. And I have said, like, this is your one and only warning. And I actually have had security escort people out of the emerge department, whether they're a patient or a family member, because I will not tolerate shit from people. But I will say though, like, I've been working at the children's emerge for the last 4 years now, and it is not as acceptable there to tell people off as it is in the adult world. And obviously you're not telling off kids, you're telling off their like entitled shithead parents, but
Yeah. Like I said, I mean, I just like people are just rude to you guys. And sometimes it torques me because like, rude. Well, and I just think to myself, like, I'm sorry, this person is trying to help you. Like, they are literally trying to make the pain stop or stop your, like, set your arm or whatever it is. Like, their job is literally to help you, and you're being a fucking asshole to them. Like, what is wrong with you? Like, yes, I get you're in pain, but like, they're trying to help you. You being a fucking asshole to them is not helping you. It's not helping them, right? Like, I mean, I get people being an asshole to us as correctional officers. They don't fucking like us. They're inmates. They hate us. They don't, right? But like, why are you being a dick to the nurse, man? Like, and I would say it all the time. Anytime I had an inmate on escort, I'd be like, they'd be being a dick. I'd be like, are you fucking kidding me right now? Like, she does not have to come back here. She can let you sit here in pain for the next 8 hours and move on to somebody else. Like, what is fucking wrong with you? What are you doing? Why are you being mean to her? And then they kind of go, oh shit. Yeah. It's like, yeah, man, like, what is, like, don't be dicks to the nurses. Like, you're an idiot.
I've actually said that to people too. I've been like, nurses will like avoid your room if you're mean to us, right? Like, we have other people to take care of, and, we will go to the nice rooms first. So I get that you're in pain, but lots of people are in pain and they're still not rude about it. So if you don't want us to avoid your room, don't be mean to us.
Yes. So I would assume that, like, working in emerge, like, obviously you have your degree, you've done all the training, which I just also want to say, I know how much work it was. I know you said that it wasn't as hard as your other degree, but I also know that I did not see you for almost 20 months because you were always in school and studying and doing labs and stuff like that. So, I mean, just kudos to you for getting done in like such a straight shot, because I think that is super challenging, and just having to literally give up everything, focus solely on school. Like, you could barely work.
I couldn't work. I tried to work, and I I took on several jobs to try and like not have, $50,000 worth of student loan debt to do this degree. And I couldn't. I like took on multiple jobs at different stages and like quit the job because I was like getting too behind on the schoolwork. And again, it wasn't hard. It was just that there was like a lot, because like we were doing classes and practicum at the same time. And you don't normally do that. Like, normally you do like just practicum. So
watching you go through it, I was thinking to myself, hold it, like, amazing that you're doing it, but wow, like, the workload is crazy. So when you get into emerge, because obviously there's got to be more things you have to learn than beyond just like kind of your standard level of nursing, I guess. So to walk me through that, like, how does that work?
Well, I mean, every unit that you go to, like if it's a specialty type of unit, they will do like their own certifications and their own training. So, I mean, like, there definitely was training, and lots of buddy shifts and stuff like that, and orientation to be in emerge. But then, nurses in emerge will take it to another level. They don't have to, but a lot of us do feel like we need a little something more. And so there's lots of different, certifications and different education. And so I did university certification through Mount Royal University, and it's an advanced critical care nursing program. And so I already knew quite a bit about emerg at this point. And so I just wanted to expand my knowledge even more. So if I remember correctly, I did the advanced critical care nursing program, but I did the ICU track versus the emerg track because I wanted to learn more critical care than what you would necessarily get in the emerg track. So that was a sort of a program add-on. And then we also have different certificates that people do, like ACLS, which is Advanced Cardiovascular Life Support, and we have PALS, which is the pediatric version of the same thing. And so people, maintain these certifications. You can do some courses and you can get, I believe you can get a certification for emergency through NINA, which is like the National Emergency Nurses Association and stuff like that. And, they hold NINA conferences all over the world every year. And there's I've personally have never been to one, but lots of my colleagues love going to these NINA conferences because sometimes it's in fun places like Orlando. So several day conference, and they teach you like lots of emergy type stuff. Definitely things to do to, advance your knowledge and keep up your skills and, learn a deeper level in emerg. And, the doctors, like they go through a very lengthy education. And now there's a lot of people who turn around and say like, oh, like you guys are so smart, you could be a doctor, which we're smart. We don't know anywhere close to all the things that doctors know. But, emerg nurses do know quite a bit of stuff if they want to.
Yeah. Well, and I feel like working so closely with other like emergency professionals, right? You kind of like pick up little things from them, just the same as we would, right? When you work with different people, you see different things. You're like, oh, that's a new way to do that, or that's a new way to kind of try that, or to, a different order to maybe run it in. So I think that's part of it too, right?
Well, and the doctors that I work with at the Foothills and the Children's emerg are so great that, if you're doing something or if they're ordering something and you don't understand why, like you don't know why we're doing what we're doing. I mean, not all the nurses will, but, a lot of us will ask like, okay, like, why are we doing this? What is this? What does this mean? And like, they'll tell you, they'll educate you, like they love sharing their knowledge. I mean, it probably also helps that, that's the teaching hospital too. So, we're always dealing with, residents and, clinical clerks from U of C's medical school and stuff like that. So, people never stop learning at the Foothills Hospital. If you want to, you can learn a lot of things, a lot of knowledge from the amazing physicians that we work with.
That's awesome of that. I think, and I mean, like, I think sharing of knowledge is huge no matter where you are. I think in a medical place, when there is so many different things, like Google Doc, and you look at 85,000 things on the internet, like you said, those doctors have to know all of those different things.
Well, and all of those things that you like, your symptoms. And the thing about Google too, is that like, it doesn't quite give you like the exact sort of nuance about your symptom that, I can now just like, look at you and like listen to your story and ask a couple questions. And I know that, this type of chest pain means this, and this type of chest pain means this, and this type of chest pain means this. And like, it's not, like if you Google, I have chest pain, it's gonna be like, call 911, go to the hospital, you have a heart attack, right? Whereas like, I like, even just the type of chest pain, where it is and how it moves gives me and my, colleagues, an indication of like the likelihood of whether or not it's like, a clot in your lung versus, chest wall pain versus just, versus, like actual true, like cardiac chest pain. So, and like, you don't get that from Google, right? That's like many years of hearing the same symptoms over and over. And like, it just comes with experience.
Well, and so tell me this, like, I'm sure you have some wild stories. We've shared some stories when we go camping and when we hang out, but share me some of your best emerge room stories? Because I'm sure there are tons.
Well, I was trying to think of some good ones for this, right? And just because like there's always like the typical stories. I mean, not typical for everybody else. Like, I tell my stories in like a group of like non-nurses, non-first responder friends, and they were like, "Holy fuck, this is your everyday life." And I'm just like, "Yeah, what do you mean?" Like they're like blown away, and I'm just like telling it like it's like no big deal.
Yeah.
Right. But for those of us who, already have some crazy stories or whatever, I was trying to think of some good ones. And one of the ones that comes to mind was this guy came in and he was brought in with EMS. His family found him. I can't remember. I think he was like in his 30s maybe. And he had like a little bit of mental health history, but he was acting like really funny, kind of like an altered LOC. Like an altered level of consciousness. And, we didn't know why. We thought it was like maybe he took some drugs. We thought maybe he was an overdose. But we sort of do like all of the things to try and figure out what's going on with somebody. So we did like the typical lab work. I think we had to intubate him because his GCS, which is like, your level of consciousness. So when you're up, talking, walking, you're a GCS of 15. If you're super altered, not really speaking, you're only moving to like really painful stimuli, then you're like 6, 7, 8 range. And if you're like completely unresponsive, no eye openings, no verbal, no movement with like the strongest painful stimuli, then you're a GCS of 3. I think he was somewhere around like the 4 or 5 range. So usually we intubate somebody that's like that just because we're worried about them not maintaining their airway. And then we took him to CT scan and we discovered what was wrong with him. So in CT scan, plain as day, can't remember if I took a picture of the actual image. I know I have a picture, but without his demographics in it. But he somehow managed to shove a pen up his nose and had a pen that we could not see. It was so far up his nose, we couldn't see it, but he had a pen literally in the middle of his brain on the CT scan. We're like, what the fuck is that? And we realized it was a pen lodged in the middle of his brain. We're oh my God. We don't know if he was attempting to kill himself by putting a pen in his brain or what. But like, yeah, he pushed it up through his sinuses and into his brain. And so we had to consult neurosurgery on this guy, and he went to the OR. I don't know how things turned out because that's the thing about emerge. You never really truly get to hear how things turned out. Sometimes you do, but I don't know how things turned out for this guy, if he has like long lasting traumatic brain injury because of it or what. But yeah, that was a very interesting CT scan and a revelation, for us. We're like, oh my God, there's a pen in his head.
That's insane. Like, yeah. And you don't see it until all of a sudden you see a picture and then you're like,
yeah. Yeah. So
I never really thought about that when you said that, like that. Yeah. You guys don't really see what happens beyond when they've been with you, because once they move on, that's it. They've moved on. Right. And like,
yeah,
on to the next person, on to the next patient, on to the next, trauma that's coming through the door. I didn't even really kind of, that's the first time.
Well, there's that part of it, but then there's also the part of like FOIP. So FOIP says that the moment that the patient is no longer under your care, you no longer like need to have access to their chart. Do you know what I mean?
Right.
So we technically can't like look a patient up, even though like we've previously cared for the patient, because it's a FOIP issue. But the doctors can for some reason. Or they can ask their like doctor colleagues, like in the other departments, how that person is doing. And so that's usually how we find out how the person is doing. Like there's one patient that comes to mind when, like follow up, I was like really desperate to know what happened. So, given my previous labor and delivery experience, a lot of times when there's some sort of like labor and delivery type of patient coming into emerge, if it's known that I'm there, then I'm one of the people that's paged to the trauma bay just because of my, previous knowledge. And the, emerge nurses don't really know much about it. I mean, like we get education on it, right? But comes in so frequently that, it just happens sort of once in a blue moon. So I was paged to the trauma bay. It was, I don't want to give away too many details because I'm worried, like, FOIP or whatever. But long story short, it was this woman who delivered in a bathtub in her home, and not under the care of a midwife, just under the care of a doula. And for those of people who don't know what the difference is a midwife is a fairly lengthy degree like program that's I believe is 4 years long in education.
Yeah.
And it's considered in other countries like Australia and stuff like that, it's considered a nursing degree, just with a focus in midwifery.
Yeah.
Whereas a doula is a labor support person, but their course is like a weekend long. Like it's literally 2 days and you're a doula. So this woman delivered in a bathtub at home under the care of a doula, and it happened to be twins, and you should never, even with midwives, never deliver twins at home because
they won't. They'll refer you.
Yeah. Well, twins is high risk. But then the other thing is that usually the one that comes out first is head down, but then the other one is not head down. Like both babies don't sit head down. So the other one either has to come out like bum first, or it kind of has to be flipped sort of in utero, before coming out. And all of these things are very risky. So they don't deliver at home. But long story short, this woman did. And apparently she started to bleed like crazy. And like, that's one of the risks of any labor is bleeding like crazy. Like I'm talking like you can lose half of your blood volume in a matter of like 15 minutes. It's insane.
Wow.
And so I know the paramedic crew that brought them in, and Krista was giving me a very quick history. She didn't know much. She just said that they saw so much blood in the tub that they basically just like scooped this woman up and put her on their stretcher and just like blazed to us like lights and sirens. And brought her straight to the trauma bay. I think all they managed to do was get an IV into her and gave her like a type of medication that stops bleeding.
Right.
But we have or labor and delivery has special medications that will help a uterus clamp down, will help they're just like, for whatever reason, they're like special medications to stop bleeding that we don't normally use in emerg. So when we know that a patient like this is coming in, we will actually call up to labor and delivery, and we will say like, we need your like little hemorrhage kit. And it's like a little tackle box of like these special like postpartum bleeding medications that you give to people. And so I was pretty much like the doctor that was going to be caring for this woman didn't even know like what type of medications to give her and like how much to give and when to give. So I'm like, you give this much and we'll throw it up in her like, bag of saline and we'll just like open it wide. I said, and then I will give her IM shots of this medication, every 15 minutes until we can stop the bleeding. But basically when this paramedic crew brought her in and moved her from their stretcher onto our trauma bay, she was bleeding so hard that I could actually see like the blood like arc out of her vagina. Like it actually like it gushed out. It wasn't just like if you can picture like, liquid coming out of something in like an arcing fashion.
Yeah.
That's how hard she was bleeding. So I immediately stabbed her with that the one medication, and another nurse started the other medication, and we continuously like gave her just medications. We have this machine called Big Bertha that basically pumps units of blood into people in like under 20 seconds, like a full unit of blood into somebody. And and then we get like a massive transfusion pack from Transfusion Medicine. So basically it's like a whole bunch of uncross-matched blood along with like platelets and like other things, plasma and stuff like that, to try and replace somebody's blood volume, because you can't just pump saline into them, because then they will have like no blood components. And she was literally, she was bleeding as quick as we were putting it into her. And the other thing is what you want to do, physician, is you need to have a sterile gown and sterile gloves on. And basically, like his job was just to shove his fist straight up inside of her and try and like clamp down and mechanically hold her uterus in a clamped fashion in an attempt to tamponade the bleeding. But basically, she was in this thing called DIC, which is basically where your clotting factors, your cascade of clotting factors is dysfunctional and is no longer working. And so your blood literally won't clot. So we took her to the ICU where OB was there waiting, and they did their thing in the ICU, which they don't normally work in the ICU, but and we just handed off to ICU. I ended up checking back I want to say a week later just to see how things were. I can't remember who I asked, probably the physician that I was working with in emerg at the time. And it was this, woman was in DIC. She almost died. And the craziest thing is that she literally got up and walked out of the ICU 5 days later and went home. Yeah.
Wow.
That was probably one of the only people I knew, post crazy story, what actually happened.
Yeah. That's insane. To know, so there's so many different facets of the story that just blow me away. So so I'll give you a quick breakdown on doula and midwife, not for you, but for our listeners, because I had both when I had my girls, as you know, and my midwife she was so funny because she was like, midwife is waist down, doula is waist up. So basically midwife is baby and waist down, vagina, all uterus, all the birthing components. Doula is waist up. They're just dealing with mom. They're there as support for mom and for husband.
Emotional support.
Yeah. Pain management, coping mechanisms, things like that. But they should not be anywhere down below waist, essentially, is what my midwife said. And I thought that was really it's just a really good way of kind of giving up that division. Right. And and then to hear as you're talking through, I'm thinking about all the things that are happening as this woman is bleeding out on this table, right? You've got blood absolutely fucking everywhere. You've got a doctor basically hand up there, like you said, manually clamping a uterus. You've got a transfusion team going on where blood is coming and things are coming and going. You've got, labor and delivery running in with their tackle box to give you what they need. There's just so many different components happening all at once. And you're in a room, not a huge room. This is not a massive room. You're in a curtained area usually when this stuff is happening. So just amazing work that you guys are doing when you're and then that she walks out 5 days later, wow. Just
yeah. I thought for sure she was going to be admitted for a couple of weeks, but nope. She bounced right back and was like, bye, within a week. Crazy.
Yeah, absolutely crazy.
She did have twins. She did have motivation. She had twins at home to take care of, which I had to at the time I had to get social work involved because those twins should have came into the hospital too. And we never to be checked out, right? Because twins, I think, they're almost never full term. And so the risk of delivery, when they're not full term is that they can't maintain their blood sugar as well, right? So they should be monitored overnight. But, so I got our social worker involved and I was trying to convince the dad to, bring the twins in because they needed monitoring. And I don't actually know if he ever did bring the twins in, but.
Wow. That's insane. What about when traumas are coming in, is there a special team that's put together versus being and I don't want to minimize the work emergency rooms are doing, but versus the, hey, I'm an idiot at rugby and I fucking fucked my back up, or I broke something and I'm waiting in emerg because it's bad enough that I should be at emerg and not at a medi center versus, okay, we've got a call, we've got a gunshot coming in, or we've got a, a mass trauma coming in. Is there a different team that gets mobilized for that?
Totally. There's, we call it a level 1 trauma. So there's a level 1 call out. And this is when we know that they're coming in, right? So, EMS will patch in, they'll give us a bit of a story, they'll tell us their vital signs. And there's certain criteria to meet a level 1 call out. Stabbing, gunshot wound are automatic level 1 call outs. I mean, maybe not, I don't think to your legs, to your extremities, but anything torso, head, neck, those are all considered level 1 trauma. there's other things too, like super low blood pressure, EMS or stars giving blood products, some sort of trauma leading to like a GCS less than 8. Those are all like criteria to do a level 1 call out. So when we do a level 1 call out, it's a massive page. And so the pages go to the trauma staff, the trauma residents. It goes to anesthesia on call. And I believe the page goes out to the OR nurses. And who else? There's a lot of people who were on that call out. And then we will also add in, like, if we know it's going to be like a vascular issue or something like that, we'll do like a separate page to vascular, just because they're not even at the foothills, they're at the Peter Lougheed. But if if there's a vascular component to the level 1, then they will come in too. But I think maybe ortho is on it, ICU's on the page. Yeah, there's like a whole bunch of doctors that are on the page. And then depending on what it is, they will come to our trauma bay when the patient arrives. But sometimes, and like this is all like, when you know that in advance and you have a nice little story and, like, what's happening. But I have been at triage where a level 1 has walked in. I was this was when I was like full time there. I was at triage all the time, like super cynical emerg nurse. I'm better. I'm slightly better now. I've my cynicism has like dialed down a bit, but this guy, like, I have a big long lineup at triage, and this guy walks past the entire lineup. And the lineup now like stands in front of you, so you can kind of like lay eyes on the lineup. Mm-hmm. But this was before our triage was renovated, and so the lineup kind of went down the side, down the hallway, so you couldn't actually really see the people like down the hallway. And so this guy like walks up, he's fairly young, walks up past everybody, bumps the line, comes up to my window and starts talking to me, even though I have somebody in my chair that I'm triaging. I'm like, yo, you can't bump the line. You got to go stand in line. And he's like, I've been stabbed. I'm like, sure, you've been stabbed. I'm like, let's see, like a totally cynical. And then he like takes this towel away from his abdomen, and he like legit has been stabbed in the abdomen. I'm like, oh, you have been stabbed. Okay, let's go to the trauma bay. I was like wheeling him past the unit clerks, and I'm like, I need our trauma team, and you need to do a level 1 call out right now, as I'm like running him down the hallway in a wheelchair to the trauma bay. Like, so they don't always come in, nicely packaged, which is, why I consider us, part of first responders too, because, I've had stabbings come up to the window. We've had gunshot wounds come up to the window. We actually had a guy shoot himself to kill himself in our bathroom outside of triage, which is pretty freaky. But yeah, it was a sad story. But yeah, so yeah, we do have a process, and sometimes the process is a little, not well managed, just because we don't know when it's coming in.
Yeah. Because you just come upon it and go, holy fuck, okay, let's respond.
Yeah. Ooh, right, you have been stabbed. Okay, let's go.
Yeah, absolutely. Oh my gosh, that's just crazy. That's just so crazy.
And I like look back at my attitude, and I was like, please, you've been stabbed, whatever.
But it's because, well, and so this is the thing, right? This is some of the challenges of these kind of types of jobs, is that you do become very cynical. You become very much like, but are you dying? No, you're not. So you can go and sit down with your, your poor broken arm that, yes, I know is very painful, but you're not fucking dying. Right. And so you do become super cynical. And then all of a sudden it's like, oh God, like I tell that story all the time of one of the correctional nurses, because we used to always have seizures. Right. And so you call the code and you kind of wander up. So we know they're faking, a epileptic seizure. And I remember the one, there's no way they could get away with it now, but she flicked him in the eye. That was their thing, right? If they were seizing, you give them a little flick in the eye. If they jerk or kind of flinch, well, they're faking. And she flicked this one guy in the eye, and it was the same thing, very laissez-faire as we walk up, like dum dee dum dee dum, and then she flicked him in the eye. We realized he was and it was like, oh shit, okay, no, this is a real one, guys. Like, I just remember that, like, no.
And it's not necessarily offside to do that, like that is one of the things that we will like do if, like, well, not necessarily like flick them in the eyeball, but we'll do like other like painful stimuli and stuff like that to see, because there are people who do fake seizures. And so, like, obviously in corrections, right? Because it buys them, buys them some time out of a jail cell, at a hospital visit or whatever. Like, I'm just feeling bored today. Let's go to the hospital,
That's
so
100%.
like, those are, those actually are like legitimate, things to do to try and see if someone is like truly seizing. So, I mean, I wouldn't like, maybe it's frowned upon in corrections now, but you would still do something like that, in emerg to see if you can, or EMS would do something like that to see if the patient is having like a true seizure or not. So,
okay. So, because I know, I don't want to take all your day because you're enjoying your day off and you've got new kittens to play with, but tell me now. So now because you've dropped down to a casual line at emerg and you've taken on this whole new, kind of exciting role. So what is it that you're doing now, and how does that kind of link into your work in emerg?
Yeah, so now, well, I dropped down to casual in both the Foothills emerg, and then I've always kind of been casual at the children's emerg. And it's just because, like it's a young man's game. I'm not, I'm not old by any means, but like it's busy, when I pick up my shifts in emerg, it's I'm usually in a float position, and in an 8-hour shift, I might get like one break, in the entire shift. And it might even be like a broken up break because, if you're afloat, then you're constantly on call to go to the trauma bay if something comes in. So, I've been in situations where I've tried to take my break 4 times and have been called back from break to go to the trauma bay. So, so it's just, it's hard to do like full time, all the time. So now what I'm doing is I'm actually working with palliative home care. And it basically is helping palliative patients stay at home for as long as possible, even up to like their death. Like, a lot of people wish to die at home. And so the majority of the people who are our patients are oncology patients who, the treatment didn't work for them, or, it was never meant to be a curative option. Just their cancer diagnosis was never, as a curative diagnosis. It was just sort of a management to give them more time. And so, our job is to sort of help them and help their families, care for them at home, as best as we can. So it's interesting. It definitely is a different role than what I've had. emerg, obviously, for the most part, you're trying to save everybody. And with palliative home care, that's not really our concern. Our concern is, making sure that everyone is as comfortable as possible. So sometimes that means like, different equipment in their home. It means medication management of certain symptoms. And when they're no longer able to swallow, which is something that happens as you get towards end of life, then you now need to have medications through like these little lines that sit in your tissue. They're kind of like IVs, but they don't go into your vein. They just sit in your like subcutaneous tissue. And we teach family how to draw up the medications and how to give the medications to their family members. And we're there for supportive management until death.
Things I could do and things I could not do. This is a job that I could not do. I know that I could not do it. And I am like, no? I remember no, there's no way I could do it. There's no way. I would become way too attached, and I would hold, like you were saying, when you didn't know what happens with emerg moving on, that would bug me. I would it would be very difficult. And it would be very difficult for me to detach from the people that I was working with. And then knowing that knowing that it had come, that their time had come and that they had passed away, there would just be, I feel like I would just fill the cup too fast, and I wouldn't be able to process, even though they're doing it in a way that's the best way for them. And that they were comfortable. And I think I would become too emotionally attached to people. And then it would just be too difficult for me to do it. I like when you said you were going to do it, I was like, what? Like, there's no way. Like, but then the more, like, again, just cause I've known you for so long and I know your personality and how you like, for you, it's humane. For you, you're seeing, like not the positive to it, because there isn't much positive to it, but you are finding the positive in how this person is living out their last days. And I think I would just be so emotionally attached, I wouldn't be able to do it. And I love that you're able to take all that experience and all that expertise that you have and be able to bring it to, like, again, full circle, right? You've gone from, and like, really, like, as I say, full circle, now that I even think about it, you've gone from prenatal and labor and delivery to emerge to now we're at palliative care. You really have gone full circle on, the cycle of life, which is crazy. Just so cool.
Well, I mean, one of the things that's sort of helping cope with this is like, you don't meet people when they're well, like we meet them when they're unwell. So we only know them unwell, so you don't necessarily get super attached because you're not in their lives when they're in a well situation, if that makes any sense. And then I too, when I was doing my orientation to this unit, I wondered how I was going to deal with it too, right? Like seeing like the sad families, and like seeing, the patients come to terms with the reality that like they're going to be dying, because usually people know for quite some time that they're dying. And I remember thinking like, oh God, like how am I going to deal with this too? Like, how am I going to tolerate this? And on our team, we have several people who are spiritual care workers, and we refer people and their families to these people who do this on our team, and they're not religious affiliated. Like originally, when I was first starting with the unit, I was like spiritual care. I'm like, ugh, eye roll, another priest or whatever. Bleh. And then what they really are people who help guide people to find meaning and hope in like, either what's left or find meaning in what has happened. You know what I mean? Like they're not religious at all. They can help facilitate religious things if people want it, but it's more like spiritual. It's more about spirit. And, one of them came and did a talk or like a quick little like hour-long info session with those of us who were training, just to like let us know who she was, who their team was, what they do. And one of the things she said during the training like really clicked with me, and it's helped me cope from here on out with, like the hard situations. And she basically said, like, the one thing that unifies all living things on Earth, whether it's humans, animals, plants, everything living on Earth, the one thing that unifies us is death. There's no other, I mean, obviously aside from creation, but the only other thing in this world that's a sure thing for everybody is death. And it's our role to help, facilitate that transition in life, to go through that life stage. She's like, it's not a tragic thing. She's like, it's a life stage that we all go through at some point. Some of us go through it earlier than other people, but all of us go through this life stage, and we're here to help these people go through this life stage. And for whatever reason, that like resonated with me, and I've been able to like help people and not get emotionally attached, because of what she said. I don't know why that clicked with me, but it's true. We all go through it.
Yeah, no, I love that. Yeah, that's such a sage piece of advice, right? Like, is that we do sometimes put a whole big emphasis on almost like the, I'm trying to think of the word, like it's not routine, but like the process of death. And, becomes a big thing. Oh, plan for this and big funeral and how, what about this and what would the person want? And it's, we make it bigger than it needs to be, I think, which is also, I mean, we don't want to minimize death, because it is
No.
it's the loss of a loved one, and it's the loss of somebody, that is needed and is loved. But, we do sometimes make a bigger deal out of it than we possibly need to. And, I actually, when you say that, I think of a good friend of mine that chose assisted dying a few years ago. And
Judy.
And she said, you guys are making a bigger deal out of this than I am, and I'm the one that's dying. And I was like, I guess, and when she kind of said that, I thought, well, yeah, we really are. And this is her, it's her choice. It's her, like, and I think it's because selfishly, as the people that are left behind, we want to keep them, and we want them to still be, here, stuff like that. So
well, and I think too, like, there's lots of people out there, and like, it really depends. Like, everyone has different religious, different spiritual, different cultural beliefs, which we respect all. We are not here to judge, or, you know what I mean, to try and convince people to be one thing or another. We are, that is not what we are about. It is, it means nothing to me. Although I grew up in a very, very, very Catholic family when I was younger, and I saw a lot of judgment, a lot of prejudice, a lot of shaming. And I just don't think that that's what is the intention, like that, if there is a God, like I don't think that's the intention of it, of that person, of that higher being. And so I personally don't, resonate with organized religion, although I respect the people that do see that, and we'll do whatever it takes to like help them, feel like that they have resolve. But for me, I think one of the things too that has really helped, and not to get like all, philosophical here or whatever, but, I've done a lot of digging, a lot of, into my own beliefs. And I am sort of the belief that, we are, souls, and our body is just, entity for our soul. And, when we die, our soul leaves and it goes to a better place. And then, at some point we'll be back. Right. And I don't know if it's in this world. I don't know if it's in another world. I don't know those things. Right. We don't know any of those things for sure, just because there's no true evidence of it. But, just because there's no evidence of it doesn't mean, in my opinion, doesn't mean it doesn't exist. And so, I like to believe that, our souls chose this, this body and this life form for this amount of time. And, then you carry on to the next one. So I like to think of it like, the soul is leaving for now, and maybe it will be back. So
yeah, I love that. That's amazing. That's a beautiful way to kind of wrap that up. I think that's awesome, because I am getting along on time for your day. Let's wrap up with a couple rapid fire questions, because I do love these ones. So I ask all of my guests, and this is a good one because you guys don't ever get a chance to actually sit down and eat or do anything when you work in Emerge. But what was your favorite, or what is, when you're working there, your favorite snack or food to eat while you're on shift?
Well, that's hard to say, because like, I love like a whole bunch of like different foods. Like, I'm super into ethnic and I go through like stages. Like right now, for whatever reason, I am like really into like Middle Eastern Moroccan food. I don't know what it is. I'm not pregnant. But I don't know. I would say like the best food to eat when you're like super busy is like whatever you get like the most bang for your buck in. So it's probably going to be pizza. And it's like literally everything all in one. You can eat it, while standing up, and like walking away. Like if you're running down the hallway to the trauma bay, you can be crushing a slice of pizza. So that's what I would say.
That's awesome. I always say majority of people do answer like something you can eat with one hand while you're driving, while you're reporting, while you're doing something. Yeah. So pizza, you roll that up, crush it. Yeah, you're good to go.
I mean, for the most part, I like almost always have like these really great salads at work. You can't eat that running.
No. You can't, and you can't eat it in a rush either, because you have to chew so much.
No, it takes forever. I know. Or soup. Like soup is really good too, but yeah, you can't eat that quick.
No. if you have an actual 30-minute break where you can sit and have it digest and not try and ram down your face.
Even then, 30 minutes for a salad or soup, even then that's hard.
Yeah, absolutely. Okay. What is your favorite piece of equipment to use, say in a trauma when you're kind of going absolutely 1,000 miles a minute?
I would probably say the one that I already mentioned, which is the massive blood infuser that we call Big Bertha. You basically you hang like a full bag of saline on one side, and you hang your blood on the other side, and you basically close this flap, and it literally pressures blood like a balloon, pushes out and just pumps against the bag of blood, and it can push a whole unit of blood into a person in I think 2 minutes.
Holy shit, that's
crazy.
And
you actually you need to, because it's so quick, you basically need 2 people managing it.
Wow. Big Bertha coming in hot.
Yeah, get Bertha ready.
Yeah. Oh, that's crazy. That's just in 2 minutes. That's just insane too.
Something like that. Something like that. Don't quote me, but it's very quick. It is super quick.
Okay. And kind of last question I would have for you. What is a piece of advice that you would give to somebody that's thinking about nursing as a career, thinking about emerg or even palliative care, looking at the different kind of facets of your career? What's a piece of advice you would give them?
That's difficult. The burnt out cynic nurse in me would be like, don't do it.
Yeah. As most burnt out first responders would say. Yeah.
Go change your mind, go become an accountant, be a company controller. Don't do it. No. I mean, if it's something that you really feel passionate about, I think the key is to be open. I had never in a million years thought that I would do all the different jobs that I have done. Mm-hmm. Including home care, including rapid, which is that, patient, transport system across the province, mm-hmm. from lower level of care to higher level of care. Never thought I would be doing that desk job. Mm-hmm. And then I also never thought in a million years that I'd be doing this private, transport job that I'm doing, where I'm flying, escorting people home from vacation who got sick or ill on vacation, escorting them home, for wherever they are. Never thought in a million years I'd be doing that either. And so I guess my point is just be open, open to new possibility, open to learning, and I think too, it's easier to be a nurse when you just accept that everyone's different and you don't pass judgment.
Yes.
Right? My job is so much more, it's easier and less painful, emotionally, and just not emotionally, but people are different, right? People do different things. There's different cultures, and you might not necessarily understand it. But if you're open and you don't pass judgment, then your heart and your brain won't hurt as much at the end of the day, because, the choices that people make might not necessarily be your choice, but everyone's different and everyone has a right to choose for themselves.
Oh, girl, that's a mic drop moment. I love that. That is, but it is because exactly like you said, your heart won't hurt as much at the end of the day. And I feel majority of first responders, we are quite empathetic people. We go mm-hmm. into these careers to help people, right? As empaths and as people that are, want to make a difference. And so we do have a tendency that our heart gets hurt, especially again, as females, right? That our mm-hmm. heart, we are emotional beings, and our heart gets hurt because we do have that sometimes good judgment, sometimes bad judgment on, well, why would they do this? Why would they make that mm-hmm. choice? Why? Mm-hmm. Or for me, dealing with inmates repeatedly being like, you shouldn't do it. Why do you keep fucking doing it? Why do you keep coming in? Right. And you get emotionally invested in these people. And I think that's a really great piece of advice. You just have to learn to kind of let that go
Let it
and
go.
just understand that they're going to make the choices that they make, and that your
Mhm.
job is basically to be there to help when they've made those choices or
Yep.
not made the right choices. Right. So
Yep.
awesome.
And some people will, like, listen to you and make better choices, but the majority of people won't, because humans are all about habits, right? Like, think about the habits that you do every single day, right?
Yeah.
I think about the habits that I desperately want to break. And, like, even though I want to break them, and even though I'm like aware of them and I'm cognizant of my behavior, I still make the same choices. It's because habits are human nature. And so, yeah, you can't take it personally.
Yeah, absolutely. Absolutely. Oh, well, girl, it has been a freaking treat and a half to chat with you today, to hear your stories. Again, new ones that I haven't heard before, which is amazing because I've heard lots of your stories. So I love these
Yeah.
ones. These are really good today. But thank you so much for sharing your time. Thank you for giving up, an hour of your day and just filling us and our listeners in on, the role of nursing and emergency room and trauma and palliative care. And yes, absolutely. Nurses are first responders, and those that say that they're not can suck my ass, because they are.
Yeah,
and
again,
you. I will always link you guys into that. Absolutely. 1,000%. So I hope you have an amazing rest of your day. Thank you again so much for coming on the show. Like, I greatly appreciate it.
Thanks for having me. And I just want to say that us emerg nurses, we love all of our first responders.
That's awesome. I would hope so, right? Because you have to deal with them all the time. I'm sure you don't love all of them at all of the time. I'm sure there's some paramedics you want to punch in the face, but that's
Totally.
that's how it goes for everybody. Right?
But that being said, there's also a lot of nurses that I want to punch in the face too. So that means nothing.
I fucking love you, buddy. Okay, on that note, I'm actually ending it. You're the best. Love you. Talk to you later.
Dude.
Well, that's it for today, folks. Thanks so much for tuning in, listening, giving me your time, your energy, and your attention. I completely appreciate it. Make sure you check out our next episode with another badass female first responder anywhere you get your favorite podcasts. And follow us on Instagram and Facebook at bluelinefitnesstesting.com. I hope you stay safe, keep your head on a swivel, and watch your six.